I'll say it's normal to be nervous or worried about perineal trauma, about perineal tears and prolapse. Um, I think it's important to focus on having a healthy baby and you being healthy and safe afterwards. And know that there is something that can be done if you do have perineal trauma or pelvic floor damage.
Yep.
We can manage it.
Welcome to the Pregnancy, Birth and Recovery podcast, the place where you learn how to prepare your body for birth and recover well afterwards. I am Kath Bequee. I'm a pelvic floor physiotherapist, mum of 3, and founder of Fitness Mama. Each week, I share practical, evidence-based tips to help you feel strong in your body, confident and supported, whether or not you're pregnant, preparing for birth, or navigating life and recovery after having a baby. From pelvic floor and core rehab to birth preparation to returning to exercise safely and boosting your postpartum recovery, this podcast is your guide to a healthier, more empowered and stronger pregnancy and postpartum recovery journey. So let's dive in. Hello, welcome back to the Pregnancy, Birth and Recovery podcast. Today, I'm chatting with Dr. Shavi Fernando, who's an obstetrician based in Melbourne, Australia, and we're discussing perineal tears. We're discussing what perineal tears are, all the different types of perineal tears, including, we also go into the labial tears, clitoral tears, and a few other tears around the area. So we discuss what perineal tears are, and then Shavi talks through the factors that we can be aware of with pregnancy, the factors to be aware of during birth, and then the postpartum recovery. So we discuss everything from, working out what one's individual risk profile is, for example, the impact of age, genetics, heritage, maternal size, baby size. We talk about perineal massage, structural size of the perineum. We talk about different positionings during birth, the pushing phase, use of forceps. We talk about warm compress, different techniques that can be used during birth to support the perineum. And then we talk about postnatal recovery. Now, before we do go on, this is a very, it's a pretty intense episode. It's a deep episode, which the subject, you would expect that listening to an episode which discusses perineal tears. But I do just want to encourage you, this will be amazing. If you're first time pregnant and you're wanting to really become informed about everything around perineal tears and birth, then I'm sure you will love this episode, but I do encourage you to stick around to the end, because if you stop listening at the halfway mark, you're going to stop listening right in the part where we're really going into the nitty-gritties of perineal tears. And when we finish it off, we really do, it comes around beautifully, and we talk about how amazing the human body is, and we talk about the postnatal recovery and all the different supports available. So it rounds off really well. So if you do listen to it in stages, even if you fast forward to the end, if you need to speeding it up, I really do want you to finish off on that beautiful light note at the end, because I guess it's a little bit of a warning. We do go into some in-depth information, which I trust some of you will absolutely love. I know I learned a lot about this, and I'm a pelvic floor physio. If you're a midwife, I trust you're going to really get a lot out of this too. It was a fantastic chat, and I trust you're going to love it. So without further ado, I will put the links to Dr. Shavi Fernando, who's an amazing obstetrician. I'll put all his links in the show notes. So if you want to go and learn more about him, you can find the details there. Before we do dive in, I do want to also let you know, inside my online app, Fitness Mama, it's all about helping women prepare their bodies for birth, having a great pregnancy experience, feeling strong during pregnancy, but also that pelvic floor side. So learning about perineal massage, learning about how to support the pelvic floor during birth, and importantly, supporting you through your postpartum recovery. if you want to come and join us for these home-based workouts, physio created, there's a free 7-day trial. Just head to fitnessmama.com. Okay, without further ado, let's get into this episode. Shavi, thank you so much for joining me on the Pregnancy, Birth and Recovery podcast for round 2. Here
Oh,
we are.
thanks, Kath. Thanks for having me again.
So we spoke a little while ago about induction of birth, which is a fabulous episode, which has received some really good feedback. And today I'm super excited to talk to you about perineal tears, prevention of perineal tears, what you love women to be aware of from a medical perspective. And I know on the podcast, I talk about, I guess, the pelvic floor aspect a lot from a pelvic floor physio point of view, but I haven't had a conversation with the doctor about it. So I'm really excited to chat. Thank you.
No, no worries. I look forward to talking to you about it.
So let's just first of all get on the same page. I know perineal, first of all, perineal tears, it can produce, like, it's not a nice term. Like, no one
Mm.
likes the thought of having a tear down there in their vagina. So I know that this conversation, like you and me will be talking about it, and it's sort of what we talk about all day, every day. But I know it can be quite stressful to hear that term, and it might be really stressful for someone to listen to this conversation. So let's just start off, like, get everyone on the same page. Can you please discuss what you mean when we talk about perineal tears? And yeah, let's just provide a little bit of reassurance first up.
Sure. So for women having their first baby, perineal tears are very common. So I think that's the first thing to be aware of. If you think about the mechanics of what's going on, you've got a baby's head, which is approximately 10 centimeter diameter, coming through a vaginal canal. And if you've never had a baby before, the vagina has never experienced that before, the physics wise, it doesn't fit. There has to be some level of tissue stretch and or tearing. However, the vast majority of perineal tears are first or second degree tears. So about 97% of perineal tears are first or second degree tears. First degree tears are tears that just go through the skin level and they don't involve the perineal muscle. So these tears are superficial. They still can be very painful, and they still often require stitches, but not always, and they still can bleed. But they're fairly shallow. They don't tend to cause long-term effects on continence or prolapse, and they recover very quickly, even with the stitches. A second degree tear is probably the most common type of tear. An episiotomy, which is where we do a cut, that's a forced second degree tear. So if you like, it's a iatrogenic or a doctor caused or midwife caused tear. Um, and the aim of episiotomy is to be a second degree tear as opposed to a third or a fourth, which we'll get to in a sec. A second degree tear is a tear that involves the perineal muscle, but not the anal sphincter complex. So basically, just through the perineal muscle. Again, these heal very well as long as they're repaired well and they're looked after well post repair. This is important too. And perineal hygiene and perineal wound care is very important if you want a good outcome long term. Plus pelvic floor physio, which is your thing, I think, Kath. Um, but perineal, so second degree tears often heal very well as well. The vagina is actually quite forgiving. If you think about what it has to go through, it actually handles itself really well. It's designed to do this. It's designed to have a baby come through it. Um, but unfortunately, tears are part of birth, vaginal birth.
And
What
then,
do you do with as a physio when patients ask you about the epinote? What do you usually say?
ooh, um, I know some obstetricians love them, and I know at
Hmm.
some clinics they have to, because they work in clinics with obstetricians, they teach all their parents about Epino.
Yep.
From what I'm aware,
Physio
the
perspective.
research, there are situations I would recommend Epino, but
Hmm.
number one, it's a little bit of a, okay. Perineal massage, it's free. There's
Yep.
no harm.
Yep.
It can be a little bit tricky to reach, but it's
Yep.
been shown to be effective, right?
Yep.
There's really good quality research. It is effective
Yep.
in for first time
Yep.
mums. The Epino, there is. there's less research, but there's even research about long-term potential adverse outcomes.
So my feeling with the Epino is that essentially what you're doing is you're damaging the vagina with the Epino because you're stretching it
You're stretching your
and
tissues. Yeah.
stretching the tissue, and you may end up with a Caesar anyway. Like
Mm.
there's
Yeah.
a
Yeah.
20 to 30% chance for your first baby you end up with a Caesar anyway,
Yeah.
and so then you stretch your vagina for no reason.
And
Um,
like the way I teach perineal massage, it's not just to push, push, push on a
this
muscle
kind of
that's
thing, yeah,
overactive. We've really
yeah,
got to work with letting go of that active muscle tension and relaxing
yeah,
and releasing. So for me, the perineal massage is more about letting go of active muscle tension
yeah,
rather than passively lengthening.
yeah,
Because to
yeah,
passively lengthen, you need to hold something a lot more than 5 minutes, 2 to 3 times a week.
yeah,
Like
yeah.
that's
It's
not
true.
where the
Yeah,
benefit of perineal massage comes from because you can't lengthen any structures 5 minutes, 2 to 3 times a week, which is what
yeah,
they recommend for perineal massage. So
mm,
yeah, that's the way I teach it. And
yeah,
look in maybe I've never actually I've talked about it and coached
mm,
women that want to use it.
mm,
Maybe in some situations with like vaginismus or
mhm,
overactive pelvic floor, but even
yeah,
then, like they don't want to be
yeah.
inserting anything into them.
It's similar feeling that I have as well. I think it can be useful for sexual dysfunction. I think
Mm.
for women who have vaginismus as well
Hmm.
but you wouldn't go to the 10 centimeters. You'd just go to how
Yeah,
much you need.
yeah.
But from a obstetric perspective, I also find it's probably a little bit overdoing it. Then you get to the third degree tears. So third and fourth degree tears are much more serious or much more um, concerning, I guess. But again, even with third degree tears, they do heal very well if they're repaired well, if they're monitored well post delivery, and if they've got proper follow up post delivery as well. A third degree tear has different grades. There's a 3A, B, and C. The 3A tear usually just involves a couple of fibers of the anal sphincter. So the anal sphincter is it's like a donut that wraps around your anus and that controls your bowel continence. And the if the surface layers are frayed or damaged, you'd call that a 3A tear. So that's up to 50% of the depth of the external anal sphincter. Um, so that maybe half a centimeter to 1 centimeter deep. Then your 3B tear involves the next 50% of your anal sphincter complex. Uh, and again, if these two are repaired well, the recovery is quite good. A 3C tear has torn through the external anal sphincter, but also involved the internal anal sphincter, which is the second sphincter that wraps just around the anus. So both of these need to be repaired properly, the external and internal anal sphincter. And then you get, and about just recently, I had a look at the AIHW rates. It's actually quite high at the moment for first births for third degree tears in the hospital system Australia-wide. It's about 5%, whereas about last time I looked was about 3 or 4 years ago in the 2000 numbers, it was about 3%. So it's about 3 to 5% for third degree tear. Fourth degree tear is about 1 in 1,000. Fourth degree tear is straight from the vagina in towards the bottom or through to the bottom. So these obviously create some terrible images in your mind when you think
Mm.
about that. But again, once again, if they're repaired very well, if the management post birth is appropriate and the follow up is good and any complications are avoided or managed well, the outcomes are quite good. Anyone who's had a third or fourth degree tear in the past is usually offered the option of a cesarean section in the second birth. That's another thing. You would say, sorry, Kath, I've been talking a lot.
Yeah, I was just going to ask about that third degree, how it's risen slightly from 3 to 5%. Do you think, well, um, what do you think is the cause of that? And do you think it's potentially because people are better at diagnosing a third degree tear and it's no longer being classified as like a second degree tear? It's a missed one. If you want to really support your recovery after birth and feel strong again, Fitness to Mama is for you. It's a physio-led platform designed to support your pelvic floor, core, and whole body. And here's the key part, it's actually best to start during pregnancy. Inside Fitness Mama, you'll find pregnancy safe workouts, pelvic girdle pain support, and guidance that sets you up for a smoother postpartum recovery without guesswork. You can try it free for 7 days, no pressure, no obligation. Head to fitnessmama.com to start your free trial.
Yeah, it could be. That's definitely, whenever you see a rise in incidence rates, that's the first thing you think of, because education has improved over third and fourth degree tears, even in obstetric trainees, because a lot of the time it'll be an obstetric trainee or a specialist who's diagnosing the third degree tear. And really, with third and fourth degree tears, the danger happens with missed tears. So
Yeah.
if you have a third degree tear and it's as identified, uh, repaired properly, and followed up properly, the outcomes are very good.
Yeah.
But if you have a third degree tear that people think is a second degree tear and
Yeah.
it's not repaired well, the outcomes are terrible.
Yeah. And I think that's a really important thing to be aware of. Um, it, yeah. So would you, and I've never actually recommended this, but if someone, this is where trust in your healthcare provider is so important.
Mm.
But let's say, unfortunately, there are women who are having to birth in, situations where they don't know who their healthcare provider or they've never met them. It might not be that trust. If it is a second degree tear, would you ever recommend for just another opinion, just to make sure it's not a missed third degree?
There are certain secondary tears which are very complicated. So it's not just always a straightforward single tear going
Hmm.
towards the bottom or anything like that. Sometimes the tears are in all different directions. They go up into the vagina, high up into the vagina, to the sides, around the anus, or towards the anus. So I think that if you're not certain about what the tear looks like, you should always get another opinion. So
Yeah.
if you're a trainee or a specialist, you just get another specialist to come and check it out for you.
Yeah.
And you're much better off doing it that way than just thinking it's okay when it isn't.
Yeah. Yeah.
Um, and the outcomes will be fine, and the patients will be annoyed about having a third degree tear or a fourth degree tear. But even though there are a lot of things that we can do to prevent them, to try to prevent them, we can't stop all of them. And when they happen to you, it's pretty doesn't feel very nice. But if
Mm.
the recovery and the repair is good,
Yeah.
then long term, you actually may not have too many issues physically.
Absolutely. You'd much prefer to have a third degree tear and know about it and be confident that it's been healed well, sutured well, rather than a second degree tear thinking you're fine and then finding out you got long-term issues with fecal
Yeah,
incontinence. Yeah.
exactly. Yeah.
Okay. So,
There's also one other type of tear which I'll just cover briefly, is what we call a buttonhole tear. So this tear is doesn't involve the anal sphincter complex, and usually even the perineum is intact. So there's no tear at the skin of the perineum on the outside. However, there is a tear that communicates between the rectum and the vagina. So this happens higher up in the vagina. So these again are very easy to miss. So often we would recommend that every woman who has a vaginal birth should have a rectal examination after the birth to check for a buttonhole tear. Even if the perineum is intact, this may be an important thing to do. So we often will give you pain relief rectally, and that rectal pain relief is really good for analgesia if you've had a tear. But at the same time, when we're giving it rectally, we can examine you rectally as well to make sure that the anal sphincter complex is intact, but also that there's no buttonhole tear
is this straight after the birth
at the
or
birth, like from the birth.
like what's that? Sorry?
It's from the birth. Like you can have. As
Yeah,
in yes, after
sorry,
we
I mean,
repair, we do it. Oh,
yeah,
straight
is
after
this
the yeah, straight after birth.
assessment
Birth week.
assessment in the birth suite or is it at the 6 week check or
Oh no, at the birth week, in the
birth
birth
suite?
suite.
Okay.
Yep.
I've never heard that, Shavi.
So buttonhole tears are much less common. In fact, I think in my career I've only seen maybe one. I think one buttonhole. They're hard to repair because their access is very difficult because
Yeah.
there's no communication to the outside. So they're harder to repair than a fourth degree tear. Um,
And
that's why it would need to be repaired in the operating theatre.
and is this just clarifying what you said? Is this the tear in the vaginal wall between the posterior wall? passage, so it
Yep.
could mask as a like a low rectocele, low
So
like
it's
down
like
the track.
on from the outside, if you just look, it looks normal.
Yep.
When you do a rectal examination, you put your finger into the rectum, your finger pokes out through the vaginal mucosa, through the vaginal skin on the inside of the vagina.
Yep.
So there's a hole between the vagina and the rectum.
Which could become a low
Um,
rectocele, like a posterior wall.
it could become a fistula.
Yeah,
Is the
right.
main concern.
Yeah,
Well, it
even
is a
worse.
fistula really because it's a
Yeah.
direct connect. So fistula means a connection between the rectum and
Mm.
the vagina, or a rectovaginal fistula, if you like.
Yeah.
Um, so again, it has to be discovered to be fixed. Um, if it's discovered, you'll be fine. Like we'll be able to repair it, and it'll recover. Probably it'll recover even better than a fourth degree tear if it's
Yeah.
repaired well. But if it's missed, it's can be pretty terrible.
And you can't assess it through a vaginal assessment?
You could, but with a vaginal examination, you can't see into the rectum. So you could
Yeah.
feel that there's something wrong, but you wouldn't really know exactly what's going on until you did a rectal examination. So because the rectum is usually much narrower than a vagina that's just had a baby come through it, um, you'd approach the tear rectally so that you could see the communication between the rectum and the vagina.
How many hospitals and doctors are doing this assessment?
You should be doing a rectal examination every delivery. So every doctor should be doing it for
I've
every
had three
delivery.
babies in the private health setting, and I've never had, not that I'm aware of, one of those.
So this is the other thing. Now when we should be telling you if we're sticking our finger in your bottom, right? We should be saying it that we're doing it.
Yeah.
The what I would do sometimes with a private patient. So, for example, the patient I delivered this morning. Okay, so for example, the patient that I delivered this morning, if she when I delivered her, she had a tiny little graze on the outside. The perineum otherwise looked very normal, very well. The birth was very straightforward, normal birth, very quick, and there was no unusual bleeding or excessive bleeding. If I chose not to do a rectal examination on her, the reason would be because it's a bit uncomfortable. That's probably the only reason not to do a rectal examination, or if the patient says no. So I told her, or I would tell her, I'm not doing a rectal examination. But what that means is if you think there's anything wrong, like if something feels not right, tell me straight away. Like
Mm.
if you feel like something that isn't right. And basically what I'm saying, and I might even say it to her, if you get poo coming out of your vagina, then tell me.
Yeah.
Um, but you're better off just doing the rectal examination because then you'll know straight away.
So it's easier if they've had an epidural, very easy for you
Mm.
to do a quick
Yeah.
rectal examination. Um, yeah, interesting. And I
Mm.
don't, do you think there's a role as a pelvic floor physio who routinely does a lot of, vaginal examination, pelvic floor examinations at the 6 week stage? Do you think there's a role for us in helping to screen this?
Well, so the questions are pretty easy. Like by the time you're seeing them postnatally, it'll either be day one or day two, like in the first couple of days after the birth,
Yep.
or 6 weeks, like after the 6 week visit. Um, by then, by 6 weeks, the patient will know because she'll be
Okay.
unable to control her bowel, and
You're
and
right.
poo will be coming out of the vagina.
Okay.
So
Yeah, yeah.
it's pretty devastating if it happens.
Okay.
It's not a common thing.
Okay. It's
In
not,
this,
it's
in this
easily
one.
picked up.
Yeah,
Yeah.
it's easily
Okay.
picked up if you look for it. Yeah.
Can we talk a little bit about clitoral tears? How
Yeah.
common they are?
Yeah, so clitoral tears. This is a one that I'm playing around with a little bit at the moment with my patients at the moment because they're pretty annoying as a patient
Mm.
and as a doctor too because they're tricky to repair, especially without an epidural. The clitoris is very highly innervated, very sore, very tender,
Mm.
lots of pain fibers in there. So if you muck up a repair or if you can't repair it well, the issues related to sexual function in particular, or even chronic um, vulval pain,
Yeah.
vulvodynia, is much like quite significant. So we often will focus much like everything. A lot of the literature focuses very much on the rectum, which is good because that's an important part too. But the clitoral tears are also really potentially devastating. So a couple of things I've noticed recently, which is if you have a catheter in your bladder, And if the catheter's tensed up or tightened up right up against your labia while the baby's head is delivering, that friction may increase labial or periclitoral grazes or tears. Usually they're shallow, but they can bleed and they can be very painful. They can be repaired, but without an epidural, the putting the local in that area can be quite painful.
Mm-hmm.
But they can be repaired quite well as long as the clinician is confident in repairing them,
Yep.
and they have to be very carefully repaired. Um, the When we talk about positioning in labour, which I think we're going to get to in a bit too, I've found, but this is only anecdotally, not any evidence as far as I'm aware, but I've found that women who give birth on all fours, they probably have less posterior tears, so less tears towards the rectum,
Mm.
but they have more anterior tears towards the clitoris.
Oh,
Um,
interesting.
so I've found that you, if it's going to happen, it's going to happen. It just matters on where it's going to happen. Um,
Yeah, fascinating.
And I wonder if that's a physics thing as well, like a
Mm.
space thing. Um, I think for clitoral tears, however, they're easily recognized because it's right there, like
Yep.
you can see it. The access to repair them is easy as well because it's on
Yep.
the outside of the vagina. So sometimes high vaginal tears that go right up into the vagina um, are very difficult to repair because you to get to that
Mm.
to top of the vagina when it's all bleeding is tricky. But the clitoral tears are right there, so
Yep.
that's easier. The main issue is around getting adequate analgesia, which can be done with local anesthetic, but that will
Mm-hmm.
sting as that goes in. And then making sure that you repair it very carefully. Little stitches close together, interrupted stitches is a good way to do it. And so that it all heals up nicely.
Yep. Okay. Right. I would love to go through pre potential predictive, like when we're looking at an individual's risk profile,
Mm.
for perineal potential perineal tears. I'd love to talk through factors we can identify during pregnancy and things to be aware of during pregnancy. Then I'd like to let's then go into the actual birth side, and then we can
Mm.
talk about postpartum recovery. Does that sound like
Yep,
a plan? So we've
yep.
talked about what they are. We've talked about, I guess, the short-term risks, pain, discomfort, healing, and then the long-term risks I think mentioned briefly, it's the fecal incontinence and inability to hold in wind. They're the main
Usually with
ones.
the that would be with the third or
Third
fourth
and
degree
fourth.
tears.
Correct.
Yep.
Yep. Yep. So, and we've talked about how it's very low risk comparatively speaking. You still got a 95% chance of not sustaining a third or fourth degree tear,
Mhm.
which is great. And they are really common, the first and second degree tears, and they generally heal really well, statistically speaking, with no long-term issues. So, now let's talk about the factors that you would love women to be aware of when it comes to knowing about their individual risk profile and whether or not that might help for a woman to decide what mode of delivery she's after.
Yep, good. There's quite a few, but I'd say probably the biggest one is if it's your first baby. So I reckon that's probably the biggest risk factor.
Hmm.
Once you've had a vaginal birth, your subsequent vaginal births, you may still have a tear, but they're usually much smaller and better recovery than
Yeah.
after your first birth. Um, if you are for tearing, there are some ethnic relationships too. So women from South Asia, women from Southeast Asia, probably more likely to tear than a Caucasian woman.
Yeah.
Fetal size is an obvious one as well. So the bigger the baby is,
Um,
um,
can we
yeah,
just go back to the ethnicity?
yeah,
I was given birth I was born in Brunei. My dad
yeah.
was working there at the time, so I don't know where, somewhere in South Asia. And mum said that they were all routinely given episiotomies, and I believe that's the case in a lot of these hospitals. Um, and do you think that that makes sense for someone who potentially is of that ethnicity? Would you be more likely to give an episiotomy prophylactically?
I've been asked this question actually by some patients. Some patients have said, "Can you please give me an episiotomy?" Because of that same
Hmm.
thing, I think. I don't routinely do episiotomies. I think personally, I don't routinely do anything. I think it
Yeah.
depends very much on the individual case.
Yeah.
So you don't really know until the head is almost crowning or
Yeah.
at crowning whether or not an episiotomy is going to make a difference. Remember, like a lot of people think that, maybe not, but there is this idea out there that doctors just want to cut stuff. We actually don't. Like we don't want to, because if we cut it, we have to repair it. Like that's
Yeah.
more work. That's more
Yeah.
stuff for us to do. But also, if we don't need to do it, we shouldn't do it.
Yeah.
But if if I do an episiotomy, it's because I think, based on my experience and what I'm seeing as the head's crowning, that you'll have at least a second degree tear anyway. So basically, what I'm going to do is do a second degree tear,
Yeah.
but no worse than what you'd have otherwise.
Yeah.
But I'm also worried that maybe you're going to have a third or fourth degree tear.
Yeah.
And so I'd rather you have a second degree tear or a forced episiotomy then a third or fourth degree tear. That's when I would cut an episiotomy because
Yeah.
I know then that I'm going to be stitching anyway. So I might as well make it as neat and nice as
Yeah.
possible and having to avoid a third degree tear.
Yeah.
But if I think you're not going to tear, or if I think you're just going to get away with a first or even just a second, then I wouldn't do an episiotomy.
Hmm. Yeah.
And even though these are risk factors, ethnicity is a risk factor, that doesn't necessarily mean that for the individual they're going to have a big tear.
Yeah.
You
And
don't
this is
know.
where the benefits of monitoring
Yeah,
are in birth, right?
yeah.
Because when you're at that pushing phase and the baby's head's crowning, do you find some positions easier to monitor than others?
In terms of, you mean monitoring the perineum?
Yeah,
Like
monitoring
looking at the
perineum.
perineum, yeah.
Yeah.
So monitoring the perineum, yes, some positions are easier to monitor than others. I think actually the easiest position to monitor the perineum in uh, would be probably on all fours because it's right there, like you can see it
Yep.
really easily. Or in lithotomy, so with the legs up in the stirrups.
Yep.
But that's depending on the tilt of the pelvis. You have to tilt the pelvis in the right way to be able to
Yep.
monitor that. The problem with all fours is you can't see the clitoris as well,
Yeah.
usually, because on all
Okay.
fours that's up underneath.
Yep.
But in lithotomy you can see both, but the perineum not as clearly as you can in all fours.
Yep. And that increases your risk of tears, doesn't it, in lithotomy? Uh,
There's some evidence that in lithotomy it can increase your risk of tears. But at the same time, if your accoucher, the person who's delivering the baby, is comfortable delivering in that position, because they can monitor the perineum well in that position, they may actually find, or you may actually find that you can get away with little tears even in lithotomy. So again,
Yeah.
evidence is tricky because
Yeah.
it's an average.
Yeah.
It doesn't necessarily tell you what the individual case is. So what I usually tell women is you should deliver in the position that's most comfortable for you to deliver in,
Yep.
and then we will manage all the other stuff. Like we'll work out how to avoid or minimize the tears or whatever we need to do.
Hmm.
But if you're comfortable, assuming you don't have an epidural, if you have an
Yeah.
epidural, you may not be able to deliver on all fours. But whatever's comfortable for you, and then
Yeah.
we will mitigate what we can.
Yeah. Okay.
Um, yeah.
Right. So back to the risk profile. We talked about first baby. We talked about genetics. Before we go on to the maternal side, the baby size that you mentioned, what age, at what age, the mum's age, would you say there's an increased risk
For tearing,
for tearing?
I reckon the older you get, the higher the risk of tearing,
Yeah.
and probably on a relatively linear to exponential graph.
Yeah.
So if you're really young, you're less likely to have a tear,
Yep.
and even if you do, your recovery will be better.
Hmm.
And as you get older, as the peritoneal tissue gets tighter, tougher,
Yeah.
then and has less stretch or less give,
Yeah.
less elasticity. That's probably the word I'm looking for. Um, then the tearing risk starts to increase again. I'd say probably above 35,
Yeah.
the
Okay.
risk will start to increase. But that's just off the top of my head.
Yeah. And so, like, putting this, okay, we'll keep talking, and then I'd like to, yeah, I will pause what I was going to say until we've
Sure.
mentioned a few things. Okay, so the next you said baby size. This is tricky with
Yeah.
imaging, right? It's not that accurate.
So I never, again, it's another thing that I see sometimes happens is patients are told, oh, your baby's going to be 4.5 kilos, you need to have a
Mm,
Caesar. and then they have a Caesar, and the baby comes out 3.2,
Yeah.
and everybody
Yeah.
looks a bit red faced. So I I wouldn't ever recommend a Caesar for just a big baby.
Yeah.
So sometimes, or just what we estimate is a big baby. Sometimes you get it wrong. Like sometimes you think the baby's little, but actually the baby's huge. It's not common though
Mm.
these days. Um, but what I might offer for women where we think the baby's big is maybe an earlier induction. So inducing the labor 39 weeks instead of 42.
Mm.
So the baby's 3 weeks smaller than it would be if you got to 42 weeks.
Yeah.
That might be something I offer to women where we suspect the baby's going to be bigger, because if we induce you, there's no additional risk to the baby at 39 weeks and no additional risk to you.
Yep. But is this where we should, instead of just talking about the baby size, isn't it more about the baby size to maternal size, like ratio?
Mm.
So, for
Yeah.
example, if you've got a 4'9" woman with, and her partner's 6'5", and they've got a big baby, that's a very different situation to a 6 foot woman who's got,
Mm.
also a big baby. So, yeah.
Yeah, you're right. So it's not just fetal size, it's also maternal size that comes into play as well.
Yeah.
So maternal stature is another big one. But this is tricky too. Like I mean, I've had patients, they've had tears, to be fair, not big ones, just second degrees, but who are little women, 150 centimeters tall, 3.6 kilo babies, which to a woman who is 5'7", 3.6 is pretty normal. Um, but for a smaller woman, particularly if you're South Asian as well,
Mm.
a larger baby, the risk of perineal trauma is higher. Um, the problem, I think, there's a big problem though, which is that you don't know. So
Yeah.
I've seen a 5 foot something woman push out a 4.2 kilo baby, and just with a second degree tear.
Yeah. And
And it's
that's the problem, right? There's no absolutes. And let's
yeah,
say you've got an increased risk profile, it doesn't mean you're still going to have that
yeah, that's
issue.
that's the challenge.
That's the
That's the
challenge. Yeah.
and I think sometimes patients say, "What do you mean you don't know if I'm gonna have a tear or not? Or what do you mean I don't
Yeah.
know if I can have a vaginal birth?" Well, we
This
don't
is
know.
my
Like,
hope. Things have improved a lot in the last few years, and this is my hope in the years moving forwards, is we will have better predictive models. At the
mm,
moment, it's still a very grey area, but I do think this area is going to change. I
yeah,
really do.
I think there's lots of work trying to be done to figure these out.
Yeah.
And you're right. I think we will get there. Probably soon. Actually, is my gut
Yeah.
feeling.
Fingers
Yeah.
crossed. Now, there's one we haven't touched on, perineal size. Because we
Mm.
know that if your perineum is less than 3 centimeters, increased risk. And again, if it's over 3 centimeters or over, reduced risk of the larger tears. What's your thoughts on that?
It makes biological sense. Like that
Hmm.
makes sense. Like if you've got a shorter perineum, you have less space between your vagina and your anal
Anus,
sphincter
yeah.
complex. So that means if you're giving birth to a same size baby as a woman who has a longer distance, you have less buffer before you hit your anal sphincter. So it would make sense that a shorter perineum would increase the risk of tearing.
Hmm.
Um, whether that would make me do a Caesar on you or not, I don't know. Like I don't know whether it's worth.
Yeah.
So sometimes when women come in to see me and they say, I just want a Caesar, I ask them why, and if they say it's because they don't want a perineal tear, the only way to guarantee you won't have a perineal tear is to have a Caesar.
Mm.
It's the only way to
Yeah.
guarantee it, especially for your first baby. But then you have a big cut on your tummy as well.
Yeah. Yeah.
So
There's no
it's
easy
sort
way
of like
out.
there's no easy way. There's no easy way out.
Yeah.
I think we're all trying to look for easy way outs, but
Yeah.
physics
Absolutely.
wise, yeah,
Okay.
there's no easy way.
So I had someone come and see me during the week, and what I love about my job is as a pelvic floor physio, I used to only see women postpartum when they had the issues. They
Mm.
had the leaking or the aches and pains, whatever it was. A lot of women are now coming to see me prophylactically for pelvic floor assessment, and they want my perspective from a pelvic floor, like physio perspective, about their birth situation. So I assessed someone, it was their first baby. They had age on their side, no issues with genetics. Oh, we haven't talked about overactive pelvic floor.
Oh,
Anyway,
yeah.
we'll talk about that. But she had a great pelvic floor, beautiful contraction, lovely ability to release, a good gentle bear down. Um, the issues with her was she had 1.5 centimeter perineum. Her mother had had a substantial perineal tear and had fecal incontinence. She
Mm.
was quite short. I don't know her size. Her partner was over 6 foot, and her baby was measuring large. And so she was in the public health system. So I encouraged her. I wrote her a letter and I said, look, I encourage you to just simply have a chat to your doctor, healthcare provider,
Yeah.
and seek that opinion because she was open to either sort of birth. And,
Yep.
she had a lot of amazing things going for her. And then there were just there were four things that I said, look, I'd love a doctor's opinion on this.
Yep. I think in that setting, there's no real right or wrong answer.
Yeah.
So in that setting, what I would do is I'd explore with the patient what the like if she did have a third or fourth degree tear, what that might mean for her, either for that like for her recovery or for her next birth, and whether that was something that would bother her enough
Hmm.
that a Caesar would have been better.
Hmm.
And then using that, we'd weigh up what the better options might be. I would also say, like if we were expecting the baby to be big, I would say, well, let's say the baby comes out 2.5 kilos. Will
Yeah.
you be disappointed that you had a Caesar?
Yeah.
If she
Yeah.
says no, then I say, all right, well then let's just do a Caesar.
Yeah.
Um, but if she says yes, then I say, well, maybe we just induce you a little bit earlier.
Yeah.
So again, I've seen it too with short perineums, and the baby's just come out and there's no tear.
Yeah.
Like it's really hard
Yeah.
to it's really hard to pick. But I think that discussion is important, and I think what you're doing is the right thing. So you ask her to raise that option or that possibility with her doctor. And the
Mm.
doctor should go through the risks and benefits in detail of a Caesar and the risks and benefits of having a vaginal birth if she's in that particular individual circumstance.
Yeah.
And then with that discussion, she should make the decision. So it
Mhm.
shouldn't be us saying, "Oh, you should have a Caesar,"
Mm.
because otherwise you're stupid. Like you're going to have a third degree
Yeah.
tear,
Yeah.
and
Yeah.
you'll be. So it shouldn't be us making that decision because we're not the ones who have to live with it.
Yeah.
We're not the ones who have to decide later on in either direction. Like we're not the ones who have to live with the cut in the tummy
Yeah.
or the third degree
Yeah.
tear or whatever. So she should be the one making that decision.
Mm.
It needs to be informed about both risks, both sides, both
Yeah.
risks and both benefits as well.
And all in a way that's not going to increase the fear because we know
Mm.
fear alone during birth, we don't want that either. We want to go into birth feeling really confident and
Yeah.
you're not
I
fearful.
think fear comes from a lack of maybe a misunderstanding or a lack of or not enough understanding of the way it works. And
Mhm.
that's
Yeah.
common. Like nobody really knows. Actually, I don't even really know how it works, right? It just happens. It's pretty cool. Like
Yeah.
it's pretty amazing that a baby can come out of a vagina. That's just fantastic.
Yeah.
Um, but that lack of understanding creates fear. Like if we don't know what we're handling, it's hard
Yeah.
to not be afraid.
Yeah, absolutely.
Um, and I think that's where the trust in your practitioner comes in handy. It
Yeah.
comes in very useful as well.
And what are your thoughts about, so now going on to that last point on my list, I don't know if you've got any more, but in terms of the factors during pregnancy that we can be aware of, in terms of overactive pelvic floor, because we know there are a percentage of women who
Mm.
they think they're lifting or that when they're relaxing their pelvic floor, they're actually contracting their pelvic floor, which means when they think they're pushing, they're actually
Mm.
co-contracting their pelvic floor. It's
Yeah,
like closing the gates sort of thing
yeah.
rather than opening up the birth canal
Mm.
and letting that baby come through. So as a pelvic floor physio, that's absolutely what we can do during pregnancy is just identify women at risk of that and then we can help support them getting the biomechanics of their pelvic floor and making sure it's all functioning properly so that when they do relax their pelvic floor, it is relaxing and when they do a gentle bear down, the appropriate muscle actions happening. Just like when we're opening our bowels and doing a poo, we want to be able to relax through those muscles so that it can all happen without having to worry about constipation and incomplete
Yeah.
emptying and all that side of things. What's your thought on that?
Yeah, I think it's good. So I think I agree. So sometimes I have patients who know they have a tight pelvic floor, like maybe they have vaginismus, or maybe they have um, they just know. And I'll suggest to them to see a pelvic floor physio, but not to strengthen their pelvic floor,
Mm,
but to teach them how to relax the pelvic floor,
yeah.
how to control their pelvic floor is probably a better way to put it, rather than how
Yeah.
to strengthen or
Yeah.
loosen.
Yeah.
It's actually how do they control it? Yeah,
What about the women that don't know about it though, Shabby?
it's hard to check these women. So you may not realize as a clinician until maybe you're
Hmm.
examining them at
Mm.
39 weeks, just
Yep.
before they're getting close to their due date, to see what they're up to. So you may not even examine them until that point. Some women you might, like during the pregnancy, there may be complications and you need to examine them beforehand, and then you might clue into it, but that's not that common.
Yeah.
So a lot of the time, unless we're clued into it, or maybe we suspect it, maybe based on those risk factors we talked about already,
Okay.
um,
Yeah.
then you might suggest it, but you don't know until you examine them.
Yeah. And this is where, like, I know some countries do this, but when we have the research to show that pelvic floor physio during pregnancy can help reduce pushing phase, we haven't even got to this yet in our conversation, but can help to reduce the pushing phase of labor. It can help to reduce pelvic floor trauma during labor. Like, we've got this research showing what we do as pelvic floor physios helps. Yet women aren't routinely referred, and the government offers no
Mm.
subsidies for women to come and see us during pregnancy, which is just crazy. But
Yeah,
anyway, that's
it's nuts. I think
it.
it definitely helps to be able to control and to be able to relax at the right time and strengthen at the right time.
Mm,
Um, and not just with the birth, but in the recovery as well, in the
yeah,
recovery phase afterwards as
yeah,
well. So there needs to be more emphasis on the physio, both antenatally and postnatally,
yeah,
for particularly for vaginal birth, even in cesarean, but particularly
yeah.
for vaginal birth.
Makes your job easier, doesn't it, Shabby?
100%. Yeah, it does.
So, ladies,
Um,
if you are listening, like, just go and find your local pelvic floor physio provider that does this sort of thing, because rather than getting, get a secondhand pram, but pay the money for a physio. Like, it would just you'll it's so worth it. Anyway, we'll stop there.
it's good.
It's a, it's really disappointing. Like, some of the stuff the government provides funding for.
Mm, mm.
Like, okay, that magnetic
Comparatively, right?
chair, that pelvic floor that chair that doctors can have in their clinic to activate the pelvic floor muscles.
No,
Oh,
I don't
anyway,
understand.
there's funding, Medicare
Is it
funding for
rubbish?
women to go sit on a chair to activate their pelvic floor, which isn't actually, anyway, we won't go there. We can talk about that off air.
But Medicare is a bit like that. Like there's some weird things that they fund that they don't, and they don't fund other things that really should be,
Yeah.
um,
Yeah.
which is such a waste. But anyway,
Anyway,
it is a chat for another day.
I'm aware of your time and I know that you're a busy man. Let's quickly chat about birth. Like,
Yep.
now, let's say, someone's come, yeah, let's just talk about the birth now in terms of
Yes.
perineal tears, and all the factors you think are important to consider. We
Mm.
talked a little bit about positioning.
Yep.
Um,
I think another big thing in birth, I think warm compresses is a good thing to use.
mhm.
Again, safe, cheap, simple,
Yep,
easy to employ. There is meta-analysis data saying that it works.
yep,
It's nice. Like the patients usually like it. Like if they don't
yep,
have an epidural, it feels nice having a
yep,
warm
yep,
compress on your perineum when it's all
yep,
stretching up and it's
good.
really sore and burning and painful. Um, so there's very little risk of using a warm compress. Maybe just make sure that you can visualize what's happening at the perineum when you're doing it. But
Mhm.
if you can do that properly, then I think it's a good thing to do. Um, I think probably a really big one is hands-on technique for birth. So that means at that last little bit, especially again, now I'm talking without an epidural, at that last little bit, when the perineum is on full distension, full stretch, that you get this involuntary urge to just push it out like as quick as you can because it's really sore. And all you really want to do is just push it out. And at that point, it's really important that you don't, that you really slow it down. And that's what the hands-on technique does. Basically, the accoucher, the deliverer, will put some counter pressure against the head as you're pushing and just gradually release that so that the head can, I guess, ooze out of the perineum,
Mm-hmm.
or out of the vagina. So that oozing out allows the skin to hopefully stretch over the baby's head and
Yep.
behind it without tearing, or minimizing tearing. And if you can, that so I think that control of delivery is actually very helpful to prevent a big tear.
Mm-hmm.
Episiotomies do prevent third and fourth degree tears. They don't stop all of them, but they do prevent them. So that's another thing to consider at birth. Again, depending on the patient, individual, and the situation, and you would only really make that decision right at the end of the birth. Um, yeah, they're probably the biggest ones I can think. Can you think of
Yep.
any others, Kat?
Well, I was going to, and this isn't so much perineal tears, but the tears of the levator ani, like the muscles
Mm,
inside the pelvis, which I think generally don't get spoken about as
mm.
much, but we do have muscles that attach inside the pelvis, and they can tear too, and they're not easily fixed. And
Can
I
you
think,
can you prevent that? Do we know
well,
any ways of
forceps
preventing
and the pushing phase are the two massive ones.
it?
So, not pushing for over 2 hours,
Mm,
and the forceps are the biggest risk factors for that levator ani, the tear.
mm. So this is another thing I hear though, and I hear from a lot of physios actually, is
Okay.
that that the forceps are the devil. Do not we tell your doctor that you don't want the forceps. Um, the tricky thing with forceps, I think there are a couple of tricky things with it. The first is that we don't know whether it's the forceps themselves or the head. The reason why we're using the forceps that
Mm,
the perineal
true.
trauma happens.
Yeah, yeah,
Um,
interesting.
so the forceps
Makes sense.
themselves don't actually expand or extend the presenting diameter significantly. What they do is accelerate the rate of delivery. So that means it brings the head through
Hmm.
quicker.
Yep.
So that speed is actually the issue rather than the forceps
Yeah,
themselves.
fascinating.
The
Yep.
speed and the mechanics, like the size of the
Yep.
head. So this would explain why, for example, a vacuum delivery doesn't have the same risk.
Mm,
It's still higher risk than the normal birth, but doesn't have the same level of risk as a forceps, because a vacuum delivery tends to be just a little bit slower. And also, vacuum deliveries tend to work with smaller babies
mm,
where they fit easier. I don't know if
yep.
that makes sense.
Also
So
with the
we
vacuum, isn't the baby further out of the birth canal? So they've already come through and they just
most
need
of the
help
way.
at that last little bit.
Depends on the vacuum. So you can do a vacuum even from a relatively high station, so relatively high in the
Okay.
vagina, but similar to the forceps. So generally, I would select a forceps over a vacuum if I think that usually it's if the contractions are not as strong as they could be, or
Hmm.
the um, the mum's getting really tired and is not
Hmm.
pushing as strongly as she has been or could be. Basically, if I'm worried the vacuum won't work, then that's when I'll use the forceps.
Yep.
Um, and if I'm worried the vacuum won't work, and that's why I'm using the forceps, that maybe that's the reason why it causes damage rather than that I'm using the forceps. The fact that I think the vacuum won't work.
And is that because you think, is this when, like, do you think it's a speed that then it comes out of the pelvis that potentially can cause that tear, or it hasn't had enough time for that muscle to stretch? Like, what?
It could be
Yeah.
either. So it could be the speed of the rate of delivery, how quickly the head comes out, because it doesn't give time for stretch, or it could be that because of the mechanics, because of the size, probably the size of the head or the position of the head,
Yep.
the the instruments are needed,
Yep.
and it's the need for the instruments that might be the issue rather than the
Yep.
instruments themselves.
Similar to the induction story, where all the
Mm, the
research behind
causes,
inductions is supposedly terrible, but if you take away all the reasons an induction was needed, it's actually
yeah,
the research is, yeah. And I'll link that podcast episode in the show notes for anyone that wants to listen to that. With the forceps, do you think it also depends on user experience in terms of
definitely.
outcome?
Yeah, definitely. Like the more forceps that the user has done, the better they will be at it. It just makes sense. Um, the other thing is selection, so that they will select it correctly rather than selecting the vacuum first,
Hmm.
and getting it wrong. or vice versa. The more experienced you are, the better you will be at it. That doesn't mean you'll escape all of the potential risks of it, but
Mm.
you will probably have a lower rate of complication than somebody who's only done five or six.
Yeah.
Um, and uh, I think one thing I hear from women sometimes, they come in and they say, "I really don't want a Caesar, I really want a vaginal birth, but I don't want a forceps." And now this is tricky, and I will always tell the patient, well, you can't really have it. You can't
Yeah.
really have it both ways because there does come a point in the birth where it becomes safer for both the mum and the baby
Mm.
to have a forceps or a vacuum
Yeah.
as compared to a Caesar. There
Yeah.
does come a point in the labor. So if you're trying for a vaginal birth, you are accepting that you may end up needing a forceps or a vacuum.
Mm-hmm.
There's no
Yeah.
guarantee that we won't be able to do
Yeah.
that. We won't be able to do that. And that's for your safety and the baby's safety.
Yeah.
And sometimes when we're doing something for your safety and the baby's safety, there are other things that can go wrong,
Mm.
which aren't deadly, but they're still pretty terrible.
Yeah.
And we would only do that. We should only be doing an instrumental when the benefit outweighs the
Yeah.
risk.
Yeah. So, how many, let's say, like what you were talking about before, the baby's head's not descending through the birth canal. Perhaps it's a bigger baby head than you realized, and you do think, okay, forceps will be helpful here. How many of those do you think could have been predicted? Well, not predicted. You can't predict anything, right? Well, but how many of those do you think? So, what I'm trying to ask is,
Should we have done a Caesar in the first place?
well, yeah, like at what point in the birth
Hmm.
would that potentially have been an option? Like, how often can you predict that a forceps might be needed? And then the woman says, no, I don't want to have a cesarean, going to keep going. And then you end up with this forceps and you're like, oh, I knew that was going to happen.
I I don't think you can. So I
No.
don't think you really can. Sometimes we say we can, like we say, she was going to end up with a forceps anyway, but I don't think you really can. I one thing I've learned fairly quickly actually in my career is you can't underestimate a woman.
Yep.
You may think that this particular patient, there is no way she's going to have a normal birth, and then she just does it.
Yep.
So there's no point in even trying to guess. I think in this
Mm,
sort of circumstance, there's too many variables involved to try to figure that out preemptively. Because what you're then talking about is you'll then do a Caesar because you know, in quotation marks, you know that she's going to end up with a forceps. But then you're doing another intervention somewhere
yeah.
else. So, and this is where that it gets very sticky, very tricky. But I don't think you really can predict it. There are risk factors, big babies, position of the baby, all these sort of things, but you don't know for sure. And sometimes you'll think the baby's a normal size, and then you put the forceps on it and you pull, and you think this is bigger than I thought,
Yeah.
and you don't even know that until you're doing it.
Mm,
And there's nothing like the scan ultrasounds have all said the baby's a
yeah.
normal size, and
And once the forceps come out, you can't then do an emergency cesarean, can you? Like
you
that.
can.
Oh, you can?
You can, but they're really complicated, or they can be
Yeah.
very
Okay.
complicated. So if you imagine the head's already low enough to do the forceps, um, sometimes there's this point in the birth canal where you will um, where a forceps or a Caesar are both equally unsafe and
Yeah.
equally safe. It's quite a narrow window.
Yeah.
At that point, we do something, or we might offer something called a trial of instrumental, which is in theatre, in the operating theatre. We do a forceps in the operating theatre. So this allows us that if the forceps doesn't work, we can go straight to a cesarean without any delay.
Uh, yeah.
So a trial of instrumental is a little bit more is well, not, it's probably the most complicated type of delivery, vaginal probably type of delivery in general,
Hmm.
um, because if you do put the forceps on and do pull, the head will get even more wedged into the vagina, into the pelvis. And at that point, and then if it's not coming further, you can't persist with a forceps because that will cause big issues. You have to abandon the forceps, in which case then you have to push the head up back through the birth canal and then do a Caesar.
Hmm.
Now, if you're reversing 12 hours of labor
Yeah.
in 10 to 15
Yeah.
seconds, that's
Yeah.
not easy and things can go wrong. We have an instrument that can help us with that called, or a device, I should say, called the fetal pillow. It's nice, it's like a little balloon that helps to push the baby's head up gently. I find that this works really nicely in the setting if you need to do it. And it just reduces the trauma to the baby's scalp or skull.
Hmm.
But it's also risky for the mum because when you're trying to dig the baby out of the pelvis by the cesarean abdominally,
Mm.
it can cause big tears on the uterus that angle out towards the sides of the uterus, and these can bleed a lot and be quite risky even for next births if she wants to have a vaginal birth the next time.
Yeah.
So a trial of instrumental can be a challenging delivery, but you don't know you're there until you're there, like
Yeah.
until you get to that point. You don't know what's going to happen until you get to that point.
That's all pretty deep.
It's intense, yeah. It's intense stuff. This is what we
Intense.
do. This is as an obstetrician. This is why this is why we do so much training. Like this is
Yeah.
why we have so much experience. Because to then also you have to identify which patients you can just do a straightforward forceps on the birth suite and
Hmm.
which patients you need to do in theatre. Because if you get
Yep.
it wrong on the birth suite, it's dangerous.
Yep. And I think this, as you said, this is an intense conversation. And if you're first time mom pregnant and you're listening to this, you might be freaking out right now. So I do just want to reassure this is why we have an amazing healthcare system in Australia. Like amazing.
We
One of
do.
the best in the
We
world.
really do. People take it for granted, I think, a
Yeah.
lot for granted. Like I haven't been overseas to work, but I hear things from America and England,
Yeah.
and people from England come here to work because it's better here. The health
Yeah.
system here is actually really, really good.
And so if you are feeling freaked out, go get a cup of tea. Like just remember, you are in amazing hands. So it doesn't matter where you are in Australia. We are so lucky. We are so lucky. And this is pretty like in some it is I feel conflicted a lot, Chevy, in terms of quite often like sometimes ignorance is absolute bliss. Would you agree?
Yeah, 100%. And I think it's very easy to just ignore, just say, no, I'm going to be great. Everything's going to go fine. I'm just going to, it's easy to do that. But I find that that it's not always like that. I
Yeah.
think it's good to be prepared. Just be prepared, and then if it all goes well, then great. You
Yeah,
know what you've had a great
exactly.
experience. But if it doesn't, you're ready for it.
And I just want to reassure all that talk of forceps that we just spoke about.
Mm.
I see plenty of women for pelvic floor rehab post forceps who have amazing pelvic floor.
Yeah,
And I
me
see
too.
many women after a, you know, theoretical textbook birth who have a
Normal
great
birth. Yeah,
birth experience whose pelvic floor needs a little bit of support. And I'm putting that
yeah.
nicely. So just it doesn't mean anything. We're sort of getting into a bit of the high level research statistical stuff, but it doesn't mean if you have forceps or if you have a long pushing phase, your pelvic floor is going to be ruined. Like it absolutely does not mean that. Sure, you might need a bit more postnatal rehab, you might need a bit more support from your healthcare team, but I have never had a woman who I haven't helped achieve all her goals post birth. If she wants to get running and she's got a big prolapse, we can help, with fitting in a pessary that fits her and help her get running again. So, worst case scenario, they might end up having gynecological surgery once they've had all their babies. But those women I don't see in the clinic. I don't know
Mm.
why, like very rarely.
I think birth is difficult. That's probably the like birth is hard. It's hard work, and again, think about it mechanically. You said this at the start as well. The mechanics of it shouldn't make sense. Like you shouldn't be able to push a baby out of your vagina. Like it just shouldn't work,
Yeah.
but it does. It's designed for it. But that doesn't come without some level of damage. And we even see it with your abdominal walls. Like when you're pregnant, your abdominal walls can stretch, and you can get the diastasis of the
Hmm.
abdominal muscles. And it's a very similar process that's happening
Mm.
in the vagina as the baby comes through it.
I'm going to pull you up on a couple of those words you just used, Shabby.
Right?
I agree. Birth changes us. Like, and
Mm,
when you say the word damage, like absolutely things do change, but
mm,
also the human body is amazing, and you'll agree with this, like amazing at recovering. Like
Yep.
the human body is built for the role of childbirth, and there's
Yep.
so much potential for recovery. So, but you're right. My abdominals, I've had three babies. I don't have the same ab definition as my 20-year-old, but that's okay. I'm
Yeah.
strong. Like I do everything I want to be able to do. I still
Mhm.
have a 1.5 centimeter diastasis, which isn't theoretically classified as a diastasis, but my abs have never gone totally back to the way they were, but they're functional, they're strong. Yeah.
I also think we maybe we look at this the wrong way as well. Like I hear it with stretch marks too.
Yeah.
It's like I feel like maybe we forget that these are marks, these are things that show that you have done the most important thing for the human species that can
Yep.
be done. Like
Yep.
it literally is the only thing that matters is that
100%. Here we've got
women
all
are
these
having babies.
creams and lotions that's trying to
Yeah,
get rid of these stretch marks instead of
yeah,
embracing them. So look how
that's it.
much ability your body has to stretch and, support this growing, beautiful life.
That's it. You've given life.
Yeah.
That's and that's for the species, for us. That's actually
Yeah.
all that. And if our mums didn't have us, we wouldn't be here.
Yeah.
The species would just disappear. We've forgotten. I think we've been distracted by all the distractions, and we've forgotten that actually all that matters is that women are having babies, and otherwise none of us would
Safely. And we're
safely,
alive at the
safely.
end of
That's
it.
it. That's it. And then
Because
life
it
at the
used
end of
to
it,
be the biggest cause of death for women.
yeah, was
Having
childbirth.
babies.
Yeah,
And now we live in we've got this amazing medical system. We are not dying. Sure, we might have a little
yeah.
bit of pelvic floor. Might need that pelvic floor rehab afterwards, but we're doing pretty well.
And we've actually got really, and like you were saying as well, Kath, we've got really good methods now, really efficient and effective methods of helping you recover.
Hmm.
And if you engage in those, often by the time you're having your second baby, you're at least fully recovered from your first.
Yeah.
And then after your second, you just do the same thing again, and you'll be better again after that.
Yeah.
Um, and uh, and
Yeah.
actually, once you've been through it, the recovery is okay.
Love it. And
Mm.
that is a perfect place to finish this episode. We didn't talk about perineal massage, which as a pelvic floor physio, I can't believe I forgot to mention perineal massage.
We
Maybe
did.
we
We talked
can,
a bit about perineal massage.
we
I think.
talked, did we?
Yeah, I think so. A
Or was
little
that
bit.
before we hit record?
Oh,
I
I'm not
might have
sure
to
actually.
slot it in. So, perineal massage, we got amazing research to show it reduces the risk of third and fourth degree perineal tears in first time mums and episiotomy too. So, it's a free tool, a free way that we can really help support our perineum during pregnancy. So, there's lots of ways we can be nice and proactive. Oh, the other thing, which we haven't talked about, Shavi, one of the best predictors of reducing pelvic floor trauma post-birth is actually to stay strong and exercise during pregnancy. It's got nothing to do with pelvic floor. If you stay fit, if you stay strong, if you continue to exercise and move your body, that's one of the best things you can do to help reduce your risk of pelvic floor trauma.
Yeah, it also helps your recovery as well
Yeah.
afterwards too.
How good's that? We don't
Yeah,
even need to touch your pelvic floor.
yeah. Just run some marathons. No, no, don't run any
No.
marathons.
But but in all seriousness, with women with pelvic girdle pain and women with nauseousness and women who are fatigued and busy with work, busy with this toddler, like it's theoretically easy. It's in real life, it can be harder to do, but again, there's lots of support available. Shavi, I think I've used up enough of your time, and I know we could keep talking, but thank you so much for joining me today. Um, if there's just one final little word, final little thing you want to impart, message, is there anything that you want to say before we wrap it up?
I'll say it's normal to be nervous or worried about perineal trauma, about perineal tears and prolapse. Um, I think it's important to focus on having a healthy baby and you being healthy and safe afterwards, and know that there is something that can be done if you do have perineal trauma or pelvic floor damage.
Yeah,
We can manage it.
yeah,
Yeah, that's probably all I'd
that
have.
is perfect. Yep. There's so much support out there if worst case scenario, there's a few issues that you need to work on. Thank you, Shavi. Thank you so much for joining me today. I really appreciate your time.
No worries, Kath. Thank you.
Thanks for listening to the Pregnancy, Birth and Recovery podcast brought to you by Fitness Mama, your app for home-based, physio-led pregnancy and postnatal workouts. If you found this episode helpful, please tap follow, leave a quick review and share it to your stories. Tag at kathbequee.physio. I'd love to connect and cheer you on. And don't forget to check out the free trial at fitnessmama.com/free to start feeling confident, strong and supported today. Until next time, remember, a strong body, a confident birth and empowered recovery is something you deserve. This podcast is for informational purposes only and is not a substitute for individual medical advice, diagnosis or treatment. Please consult your healthcare provider for your personalised guidance.